One of the things we've been talking about the whole podcast is the value of standardization. One of the mistakes that we often have with standardization is we think there's one process that will solve all. And what Nelly just referred to is women are a big part of the population, right? Standardization is one thing, but differentiation within the standard is important, right? So as a woman representing also women homeless as homeless individuals, is there a different application of MED4HOPE for women, or what are some of the classical considerations that have to be covered from a female perspective?
One first is that women can get pregnant.
Okay, so the pregnancy factor?
So the pregnancy factor is with migrants in Austria a huge problem, because the young Roma girls, they are like 20 years old and have their 5th pregnancy. Okay. And you have to talk to them alone, because when the man is with her in a consultation, they can't tell what they really think. They have a huge cultural issue with pregnancies and getting pregnant and getting children, even if the children won't stay here. They go down there to Romania or somewhere else, get the children, and they live in the streets, even the children alone. But the girls come back, or they kind of interrupt the pregnancy in the streets of Bucharest.
So having sensitivity to who's in the presence of the client.
Yeah,
this has a huge aspect. Yeah, maybe correlative, but not the same thing. Also with human trafficking, I remember you've had a couple issues where you suspected that the patient that you were treating was being trafficked, right?
Yeah. And female women, when they're living on the streets, they have to find somebody who protects them, and very often this person protects her but uses her. Yeah. So if she's not homeless, she has a home,
she's
but
codependent or worse.
She is actually homeless, but she is allowed to live somewhere with a guy.
Oh, I remember you telling me there's some homeless people who will do couch surfing, if you want to call it that.
If you make a very cynic statement, you could say, cynical statement, you could say that she knows who is going to rape, she's going to be raped when she lives with a guy in a home and in a park. She does not know.
It might not be non-consensual, but it might be what we call semi-consensual relationships with somebody, because he's allowing them to live in their house.
What's for us important, if we have such a woman, and she comes to our mobile team, and very often they come with an interpreter because they don't know the language. And usually I'm happy to have an interpreter because it makes the treatment more easier. But
although you do use software, right?
We have it. But if a woman comes with a guy, first I try to find a solution without him. Yeah. Only if I really feel that this woman needs the guy and she's really, he's a good guy.
One of the things you have to look out in your medical services is that you assess the situation to see, is there a potential
if there's
criminal
a guy
situation?
Who brings another 2 men, one brings in another, and he says, listen, this doctor, she helped me, maybe she can help you, and then we just talk. But if a man comes with a woman.
From a dominant position.
Yes, and I always asked him to wait outside. And even if the lady says, oh no, it's no problem, he can stay here, he's my boyfriend. And then I say, no, I'm the doctor. It would be better. Maybe, sir, please, could you wait outside? I'm very polite.
So part of your training program is also the sensibilization towards,
does she, when there's one woman.
So this is probably not classical medical training, but so you also learn things from other disciplines, like from social.
Yeah, of course.
Okay.
My patients in my office, in like Vienna, they never come with their husbands who protect them and go with them to the doctor. Like women like us, we come alone to our doctor, but they always, very often, these homeless women, they come with somebody, and you never know if he really protects her Or if he just uses her, and first of all, I want to talk to the woman alone.
You have the whole reproduction issue. You have the whole female hormone issue.
And
you have certain medical conditions that are probably specific to women, and you have the whole criminal human trafficking aspect that you have to be sensitive to as well.
I don't know if there are any studies, but to me, it seems that there are a huge part of schizophrenic women. Either they get that schizophrenic or they had it before.
So I was going to ask you more specifically, where do you find more mental health issues or more difficult or more egregious, more heavier mental health issues with females or with men?
With females.
Oh, interesting.
Yeah, I think so. Yeah. Yeah, the anxiety problem. If you sleep alone in the park and you're a guy, you might get raped, you might get attacked, you might get there might be a robbery. But if you're a female, I could not think of sleeping in the park alone, actually. So that's another issue.
The female population, generally speaking, is just more vulnerable to the external. Yeah. And it might be a generalization, but maybe also that I find that generally speaking, that the female population might also be more emotionally sensitive, and I don't mean that as a negative quality. So they might be might not be as resilient to the conditions that they live in. Yes. Okay, good.